Good morning, everyone.
Good morning.
At the outset, I wish a happy Women's Day to all. And I am really happy that on the Women's Day, I am presenting this topic. You all know it is said that birth of a baby is also a rebirth of the mother. And there are so many things that can go wrong during a pregnancy. When you see this picture, we know that how many complications can occur during pregnancy. And one of the most dreaded complication, as far as we anesthesiologists are concerned, is maternal cardiac arrest. In today's topic, I am going to mainly focus on prevention and management of maternal cardiac arrest or cardiac arrest during pregnancy. Statistics suggest that there is 27% reduction in maternal mortality rate since 2013. And that is mainly attributed to health improvement in or advances in healthcare. But surprisingly, even though maternal mortality rate has decreased, the incidence of cardiac arrest is on rise. What are the causative factors for that? It is said that more and more number of women are seeking pregnancy at a later age, that is elderly priming, who are more than 35 years. These are those with associated lifestyle diseases. These women are seeking pregnancy, and the advances in medical care, which has led to improved survival and quality of life. These women with underlying serious medical conditions, they are carrying success pregnancy till term. And these are the women that are likely to land up in cardiac arrest. And recent data suggests that if mother lands up in cardiac arrest, the rate of survival is only 59%. So almost half of the mother who land up in cardiac arrest, they die. Can we do something to improve the outcome? The maternal and fetal outcomes improve with knowledge of physiological changes during pregnancy. Know what are the risk factors for cardiac arrest so that you try to prevent the patient landing up in cardiac arrest. We should know thoroughly about BLS and ACLS protocols. We should know what are the changes in CPR protocols during pregnancy that is recommended by American Heart Association. And last but most important is skills training. So what are the physiological changes that affect the outcome of CPR? There are so many physiological changes. Pregnancy affects almost all systems in the body. But few of the physiological changes I'm going to highlight which are affecting the outcome of CPR. The first is increased cardiac output during pregnancy that leads to increase in circulatory demand. So maintaining effective cardiac output during CPR is very, very essential. There is increased blood volume during pregnancy, but at the same time, there is decreased oxygen carrying capacity. So oxygen supplementation becomes very important. After 20 weeks of gestation, the mother is likely to have aortocaval compression because of the pressure of the gravid uterus. Hence, to relieve this complication, lateral uterine displacement is indicated. Also, we all know that during normal pregnancy also, the woman is having airway edema and there is weight gain. Airway edema and weight gain, and normally also, but if patient is having PH, there is a lot of airway edema making the difficult mask ventilation and intubation. There is, because of fetus oxygen consumption, there is increased oxygen consumption, as well as because of pressure of gravid uterus, their diaphragm is shifted upwards, leading to decreased functional residual capacity, FRC. All this lead to rapid development of hypoxia. Mother doesn't tolerate periods of apnea well. There is decreased gastroesophageal sphincter tone and decrease in gastric motility. Also, because of hormonal actions, there is increased acidity of stomach contents. This makes the pregnant woman at increased risk of regurgitation and aspiration. What are the common causes of cardiac arrest during pregnancy? We can remember these causes as A, B, C, D, E, F, G. A for anesthetic complications and road traffic accidents. B is for bleeding, antepartum as well as postpartum. C for various cardiovascular diseases, congenital, rheumatic, myocardial infarction, cardiomyopathy. Because as I already discussed, because of improvement in healthcare, more and more number of patients with cardiovascular diseases, now they come with pregnancy. D for drugs. The most common drugs, these are contributing to cardiac arrest during pregnancy, are overdose of magnesium, local anesthetic toxicity, especially while giving labor analgesia, and also drug abuse. We feel that drug abuse is mainly in the Western population, but it is not so. The younger generation in India also, especially in urban areas, now they are going towards drug abuse. So drug abuse is also one of the common causes of cardiac arrest. Then E for embolism, amniotic fluid embolism and pulmonary thromboembolism secondary to DVT. Infectious causes, F for fever, infectious causes, maternal septicemia. G for general causes of cardiac arrest. We see 5H, 5T like hypoxemia and electrolyte disturbances, etc. 5H, 5T. And H is for hypertension, preeclampsia and eclampsia, chronic hypertension, preeclampsia and eclampsia. These are the common causes of cardiac arrest during pregnancy. So whatever may be the cause of cardiac arrest, the treatment largely remains the same. We know in community medicine, we learn that prevention is always better than cure. So timely recognition of a pregnant woman at risk of developing potentially life-threatening complications goes a long way in prevention of patient landing up in cardiac arrest. For this, use of a validated obstetric early warning score is important. There are so many these warning scores are available if you go through the literature. This is the most commonly used one. This is color-coded early warning score chart by Carl et al. You can see the colors. See, the green one means mother is safe. Yellow, this color yellow means you should be cautious, and this red one, that means danger zone. So there are 6 parameters: systolic BP, respiratory rate, heart rate, requirement of oxygen supplementation to keep saturation more than 96%, temperature and consciousness. It has been given points 3, 2, 1, 0 like that. And the sum of all these parameters, if a score is more than or equal to 6, that suggests that this patient needs continuous monitoring of vital signs. So when you monitor this patient and you feel that this patient is unstable, and this unstable likely to progress to serious complications. Then what you can do? First and foremost thing is place the patient in full left lateral decubitus position to relieve aortocaval compression. That will improve the cardiac output of the mother as well as improve blood supply to the fetus. Administration of 100% oxygen by face mask with reservoir bag to prevent or treat hypoxemia. The important thing, intravenous access should be established above the diaphragm because of the chance of aortocaval compression. Even if you want to take central venous access, femoral access should not be taken. Either IJV or subclavian access is preferred. And think of the causes of cardiac arrest as we discussed earlier, A, B, C, D, E, F, G. Look for precipitating factors and try to treat it. After taking all these precautions, trying to prevent the cardiac arrest, there are some patients who will end up in cardiac arrest. Then what we should do? Do not forget BLS and ACLS protocol. First, we will see about BLS protocols in pregnancy. As in non-pregnant patients, BLS constitutes CABD, C for chest compression, A for airway management, B for breathing, and D is defibrillation. This is the AHA algorithm, American Heart Association's algorithm, when patients land up in, pregnant patient lands up in cardiac arrest. It is same as if patient is unresponsive, activate, call for help, check pulse. If no pulse, then start high quality chest compression, look for ventilation and defibrillation. So the algorithm remains the same, but see, I have highlighted 2 points. When you call for help, see that minimum 3 additional members, they come for the help. Why? I will discuss it subsequently. And another most important thing is document the time of starting of, document the time of cardiac arrest. These are the 2 important things that you should do when you are giving CPR to a pregnant patient. Again, how will you give chest compression? Patient to be placed in supine on firm board. It is same as non-pregnant patient. Again, the site of compression is lower half of the sternum. Rate of at least 100 per minute, 100 to 120. Depth of at least 2 inches, that is 5 centimeter. Allow full chest recoil with minimum interruptions less than 10 seconds and compression to ventilation ratio of 30:2. Again, the important thing, continuous manual left uterine displacement when the uterus is at or above the umbilicus. Why we require manual left uterine displacement? Previously, it was said that either you do manual left uterine displacement or you can tilt the table by 30 degrees so that it will achieve the same result of relieving the aortocaval compression. But recent guidelines suggest that this tilting the table to relieve the aortocaval compression in patients with cardiac arrest is not at all effective, because when you perform the chest compression in a patient, when the patient is in a tilted table, it is significantly less effective than when the patient is in supine position. So what is advocated is manual lateral uterine displacement. If you are standing on the right side of the patient, you can do this maneuver with using one hand. You can push the uterus to the left side with your one hand. And when you are standing on the left side of the patient, you can pull the uterus with both your hands on the left side. Airway and breathing. Ensure the maternal oxygenation and ventilation. We saw that during physiological changes of pregnancy, the mother is highly susceptible to hypoxia. So oxygenation and ventilation is equally important. Perform bag mask ventilation with 100% oxygen flowing to the reservoir bag at the rate of at least 15 liters per minute. This is the reservoir bag that you can attach to the umbo bag. And when you keep the flow rate of 15 liters per minute, then you can deliver approximately 100% FiO2 to the patient. And as there is difficult chances of difficult mask ventilation, wherever possible, two-handed bag mask or holding the mask using two hands, you will be able to ventilate better. Then defibrillation, it is same as non-pregnant patient, that is defibrillation with biphasic shock using 120 to 200 joules. Biphasic defibrillator has a maximum of, usually those that are available here are having maximum energy of 200 joules. So if you don't remember how much joules you should give whatever maximum available on the defibrillator. Compressions should be resumed immediately after delivery of the electric shock. And how the pads are placed, it is anterolateral pad placement. This is the pad on the right that should be placed just below the right clavicle. And this is the apical pad, which is usually placed on the apex of the heart. But in pregnant patient, the breasts are enlarged. So this pad is placed under the breast tissue on left side. If we feel that our ECG rhythm recognition skill is not up to the mark, this is a very good alternative to the manual defibrillator, and that is called automated external defibrillator. It is very useful in, especially out of the OT and ICU, that is especially in wards or during transport also. It automatically identifies the rhythm, suggests whether shock is indicated or not, and you just have to apply the pads, then the machine will automatically detect the rhythm, and if shock is advised, machine will tell that shock is advised. You will just have to press the shock button and machine will deliver the shock. These are the basic BLS or basic life support protocols. But since we are anesthesiologists, we all should be aware of ACLS protocols, because in OT, we are the ones who will deliver this advanced cardiac life support to the patient, pregnant patient in cardiac arrest. Since these patients are susceptible to hypoxia, also these patients are susceptible to acid aspiration syndrome, endotracheal intubation should be performed as early as possible and by an experienced person, because the chances of difficult intubation are also very high. And use a smaller size endotracheal tube, because there are chances of airway edema. And the plan B should also be kept ready. If intubation is not, you cannot do endotracheal intubation easily, then supraglottic airway placement LMA is the rescue strategy. And wherever possible, use a second generation LMA, that is the one with gastric drain or second channel through which we can put Ryle's tube, so that we can empty or aspirate the stomach contents to decrease the chance of regurgitation and aspiration. Continuous waveform capnography, that is monitoring of EtCO2, is the most reliable method of confirming and monitoring correct placement of the endotracheal tube. as well as to monitor the CPR quality. If EtCO2 values are above 10, that suggests you are giving a good quality CPR. If not, you can improve the your chest compression so that the values EtCO2 values should be above 10 millimeter. Which are the drugs that can be used in ACLS? No medication should be withheld because of concerns about fetal teratogenicity. All the commonly used medication for non-pregnant patient are safe for use in pregnancy also. The doses are also the same. The most commonly used drugs are adrenaline, given 1 milligram given every 3 to 5 minutes. And if patient is having VF or VT, another important drug is amiodarone, 300 milligram can be given and can be repeated if no response to 300 milligram. Also, if amiodarone is not available, you can use preservative-free lignocaine also for the same purpose. Again, when mother lands up in cardiac arrest, what should we do about fetus? Always it is said that mother should have the highest priority and not the fetus. So fetal assessment should not be performed during resuscitation. If there are fetal monitors in place, it should be removed as soon as possible to facilitate perimortem cesarean delivery without delay or hindrance. Now, a few words about perimortem cesarean delivery. I am sure we have not encountered this perimortem cesarean delivery. At least I have not encountered, and very few of you have done this perimortem cesarean delivery. But they say that if you do it within time, it gives the mother as well as baby both the increased chance of survival. But the main purpose of perimortem cesarean delivery is to facilitate resuscitation of the mother by relieving aortocaval compression as well as improving respiratory mechanics. When we say cesarean delivery, we think it is for the baby. But the most important purpose of perimortem cesarean delivery is for the mother. When you relieve aortocaval compression, naturally it improves the cardiac output. Also, it relieves the pressure on the diaphragm. The FRC improves, improving the oxygenation also. So, the circulation and oxygenation both will be benefited by delivery of the baby. Also, early delivery of baby will help fetus also. There is less risk of permanent neurological damage to the baby due to hypoxia. So, in which patient you should do PMCD? It is strongly considered for every mother with more than 24 weeks of pregnancy. That means after 24 weeks, you are giving some chance to baby also of survival. When return of spontaneous circulation is not achieved after 4 minutes of resuscitation. It is said that you start the cesarean at 4 minutes and deliver the baby by 5 minutes. So within 1 minute of starting the cesarean, you should deliver the baby. Incision to delivery time, 1 minute. So, do cesarean section is necessary every time? No, if you feel that if cervix is fully dilated and fetal head is at appropriately low station, assisted vaginal delivery also is equally helpful. Cesarean delivery should be done at the bedside. It is said that even in emergency department, even in casualty also, you can perform this cesarean section. And no need of doing lengthy antiseptic painting, draping. Do not waste much time in doing this antisepsis. It should be started as early as possible. And only 3 things are needed: scalpel, artiforceps, and mops. Chest compression should be continued only. It should be stopped when you are actually delivering the baby. And continuous manual left uterine displacement should be done throughout the cesarean delivery until the fetus is delivered. I am not going into details of technique of PMCD, but the important point I want to highlight is wait for return of spontaneous circulation before closing the abdomen. Because you take the uterine suture, put the mops, and wait till mother sorry, till return of spontaneous circulation. Why? Because when patient is in cardiac arrest, BP is very low. And when there is return of spontaneous circulation, there will be some bleeders in the abdomen that can later on again land up a patient in shock. So to assess about the hemostasis, you should wait for return of spontaneous circulation before closure of abdomen. Another word of caution is about oxytocin use. You all know that oxytocin causes hypotension. So indiscriminate use of oxytocin or high dose of oxytocin can cause again patient having rearrest. So oxytocin should be used very cautiously. This is the 2020 AHI algorithm for maternal cardiac arrest. If patient is in cardiac arrest, high quality CPR, defibrillation when indicated, ACLS intervention, that is use of drugs like adrenaline, assemble maternal cardiac arrest team. Remember, initially I said that when you call for help, you call for at least 3 persons. Why 3 persons are needed? The one is for giving cardiac compression, one is to take care of ventilation, and one is for defibrillation and giving drugs, and one person is specifically allotted the role of continuous left uterine displacement. So one additional member is needed when you are giving or you are doing the resuscitation of pregnant mother. That is the one who will give continuous manual left uterine displacement. And again, document time. Why document time? Because if you are not able to revive the patient within 4 minutes, at 4 minutes, you should start doing cesarean delivery. Hence, documentation of time is also important. Then perform maternal interventions like doing endotracheal intubation. If failed, then you can use second generation supraglottic airway devices. Administer 100% oxygen. Place IV above the diaphragm. And this is another important thing, especially if patient is having preeclampsia. They usually receive IV magnesium. This IV magnesium can also lead to cardiac arrest, as we have seen during the causes of cardiac arrest. So stop IV magnesium and give calcium chloride or calcium gluconate. These are the maternal intervention. What obstetric intervention you want to do? Continuous left lateral uterine displacement manually, detach the fetal monitors, and prepare for perimortem cesarean delivery. Again, continuous BLS, ACLS protocol or BCL intervention should be continued, and perform perimortem cesarean delivery if no return of spontaneous circulation within 4 minutes, and baby should be delivered by 5 minutes. Neonatal team to receive neonate. So my take-home message is BLS and ACLS algorithms are backbone of treatment of maternal cardiac arrest. While doing resuscitation of pregnant patient, Special attention should be paid to manual left uterine displacement, difficult airway management, that is the use of LMA, and appropriate use of perimortem cesarean delivery. Life-saving interventions such as defibrillation and medication should not be withheld just because there is presence of fetus inside the mother. And most important thing is training, because we feel that we should not encounter cardiac arrest during pregnancy, but it is a once in a lifetime, maybe once in a lifetime situation for most of us. So how do we keep train ourselves? So training of or everyone who is involved in caring for the mother, right from our obstetrician friends, the nurses involved, and operative room the personnels, apart from ourselves, they all should be trained in BLS, giving BLS and ACLS care to the pregnant patient. So training is most important if we want a successful outcome of the cardiac arrest. These are my references. Thank you.